All right. Hello. I could not figure out how to put the narration on the PowerPoint slide. So instead, I'm posting this maybe on YouTube, maybe on Canvas. You should play it in the background, but while you're listening to it, watch the PowerPoint slides that I have posted on Canvas. And you can listen to what I'm saying while you're watching the PowerPoint slide. I'm going to finish up the lecture on treatment for panic disorder and agoraphobia, and then going to talk about obsessive compulsive disorder in this lecture. Then I'll make another one for post-traumatic stress disorder. All right. First, talk about treatment of panic disorder. There are medications that are effective in treating panic disorder. All of the medications that have been found to work with depression and anxiety have some effect with panic. The tricyclics like imipramine, SSRI, which you know stands for selective serotonin reuptake inhibitor, and those are drugs like Prozac and Paxil, and the benzodiazepines, which are the main anti-anxiety drugs like Valium or Xanax. These drugs do have side effects, and it's important to be aware of that. For example, about 3/4 of patients on SSRIs like Prozac report having a sexual dysfunction, usually in the form of decreased sexual desire or potency. I'd like you to keep that in mind. That could be relevant for some things that you're going to be seeing later this week. Of those drugs, the SSRIs are the most commonly prescribed for panic, and about 80% of patients who get drugs for panic disorder do show some response, which means some improvement. On the other hand, the relapse rate is very high when those drugs are discontinued. But there's also psychotherapy, which has been found to be very effective with panic disorder, as effective or more effective than medication. A common theme that we'll see throughout the class is that while there are billion-dollar international corporations that spend millions of dollars convincing Americans that medication solves their problems, there isn't any big industry that spends millions of dollars getting the word out about the effectiveness of psychotherapy. The main treatment for agoraphobia is called exposure. That's a kind of behavior therapy. As I said last week, agoraphobia is really best thought of as a kind of avoidance response maintained through negative reinforcement. When you avoid something that you don't like or are afraid of, it makes you feel better, which makes you more likely to avoid it in the future. The most powerful treatment for panic disorders is in vivo exposure, where we force the patient to experience the situation that they're afraid of. We combine that with relaxation, which we've taught the patient how to do, and it partially extinguishes the panic produced, or at least associated with, a particular situation. And if that happens, then it reduces also the need for any agoraphobic avoidance of that situation. So, for example, if you've been having panic attacks, or at least you're afraid you're going to have panic attacks when you're on a bridge, if we do in vivo exposure, we will extinguish your fear of the bridge, and then you won't need to avoid it anymore in the future. Exposure is effective in reducing agoraphobic avoidance, but it rarely cures panic disorder. Or, I'm sorry, it rarely cures agoraphobia. The best treatment for panic disorder is called panic control therapy, sometimes abbreviated as PCT, panic control treatment or panic control therapy, which is a cognitive behavioral intervention. Panic control makes use of something that in your textbook is described as biological challenge tests. Basically, we expose the patient with panic disorder, to the internal sensations associated with their panic attack. We basically make them have a panic attack in our office, a controlled panic attack. They have the autonomic nervous system symptoms, the sweats, the heart palpitations, the dizziness, and so forth. And then we use cognitive therapy to help the patient more accurately identify the physiological sensations that they're experiencing and then properly interpret them. And so rather than saying to themselves, we teach them to be aware of the thought, my heart is beating fast, I must be having a heart attack, I'm about to die. And then we teach them to modify that thought. My heart is beating fast, it's probably because I've been hyperventilating. If I stop hyperventilating, my heart won't beat so fast. It doesn't mean I'm about to die. And we do that over and over again with lots of different of the internal sensations associated with panic. And that has been extremely effective. And what panic control therapy basically is a form of exposure therapy combined with relaxation training. The client realizes the thing they're afraid of is not so bad, and their fear begins to extinguish, along with more adaptive and accurate ways of thinking about what they're going through. That's why we call it cognitive and behavioral. It's both. Now, I want you to think about panic control therapy in particular as you, well, I'll come back and talk more about that in a minute. Okay, good. Combination therapy refers to combining medication and psychotherapy together. For some disorders, combination therapy seems to improve effectiveness, but I'd say for most disorders that is not true, and it's not true in the case of either panic disorder or agoraphobia. There is no benefit from combining the two. As I said, psychotherapy of the kind I've mentioned here is at least as effective as medication in treating panic and agoraphobia. It's probably more effective. Plus, psychotherapy lasts longer after it's discontinued. There's less chance of relapse after you stop the medication. There almost always is relapse, whereas psychotherapy teaches patients skills that last long after the therapy has stopped. I often say that the benefit of combination therapy is not so much a stronger magnitude of effect, but you can get a quicker response from medication. And then if you combine that with psychotherapy, you'll get a longer lasting response. One thing I usually say is anybody who has a serious enough mental disorder that they need to be on psychotropic medication also has a serious enough mental disorder that they should be in psychotherapy too. All right, that's the end of panic and agoraphobia. Now we're going to talk about obsessive compulsive disorder, which we often refer to as OCD. I've listed there again the DSM-5 obsessive compulsive and related disorders. The one I'm going to talk about from that list is OCD. Remember, body dysmorphic disorder is now in DSM-5 classified as obsessive compulsive, but we'll be talking about that as your textbook does under somatic disorders. Obsessive compulsive disorder is considered by most experts to be the most severe of all the anxiety disorders, or anxiety-related disorders now, because it's not anxiety anymore. It's the most severe of really all the non-psychotic disorders. Um, it can be paralyzing. It can be render the person non-functional in society, and in many ways, it's a borderline condition to psychosis. Um, it's characterized by a profound and pervasive fear of internal events, things inside the person, their thoughts or their impulses to act, their predispositions to act. It's not a fear of external stimuli, which is what most anxiety disorders are. The life of a person with OCD, as I say, can be completely consumed by their own attempts to avoid fear of their own thoughts. And of course, when it comes to your own thoughts, you can run, but you can't hide. They're with you wherever you go. Let's define our basic terms here. When we talk about an obsession, we're talking about intrusive, repetitive thoughts, mental images, or impulses that the person finds difficult to control or to resist. They don't usually act on these intrusive impulses, but they feel like they're going to, and it's scary. And often the impulses are things like kill their husband or jump off of a building or something like that. Obsessions can be distinguished from normal recurring thoughts because obsessions are distressing and unwelcome. They're internally generated. They're not cued by being in some particular situation. And they are very, very difficult to control. We all have thoughts that we don't like to have sometimes. Think about bills or bad grades or relationship that isn't going well. Most people are able to distract themselves or change the subject inside their head and think about other things. People with obsessions are locked into these very, very, very distressing thoughts and they can't get away from them. A compulsion has to do with rigid rituals, action patterns that must be performed. Classic compulsions are hand washing or door checking or checking to make sure the oven or the iron has been turned off, lights have been turned off, things like this. A compulsion can also refer to a thought, which can sometimes make them difficult to distinguish from an obsession. The obsession is the distressing, intrusive thought. The compulsion is a thought the person engages in to try to get themselves away from the obsession. Compulsions are negatively reinforcing. When you engage in a compulsion, you get relief from the horrible obsession underlying it. And of course, that makes it more likely to be repeated in the future. Compulsions should be distinguished from addictive behaviors. And we'll talk later. There's a controversy in DSM-5 over how things like gambling should be classified. Drugs are addictions. There's a discussion about whether sex can sometimes be an addiction. You might recall Tiger Woods talking about being addicted to sex. Sometimes we refer to addictions as compulsions, but true compulsions cause distress, whereas addictions are pleasurable behaviors. Drugs or sex or the internet, television, eating, these are things which, when done to excess, can be problematic, but we're not puzzled as to why people want to engage in them, at least initially. They are pleasure-giving activities. Compulsions are not intrinsically pleasurable. They are engaged in to excess, always, and often, although not always, the person with them would rather not have them, and yet they can't stop. All right, now we're going to look at DSM criteria. I see for DSM-5 criteria for OCD. Criteria A is the person has obsessions, compulsions, or both. You can have either one or both of those. Obsessions are defined by both 1 and 2. One is recurrent and persistent thoughts, impulses, or images that are experienced, at least during some part of the disturbance, as intrusive and inappropriate, and in most people cause marked anxiety or distress. We say at some time during the disturbance because often people who've had OCD for a long time transition out of a time when they realize there's something wrong with the obsessions, they don't want to have them, to a time when they just kind of give in to them and don't no longer define them as unusual or uncontrolled or unwanted. The second aspect that makes something an obsession is that the person attempts to ignore or suppress their thoughts, impulses, or images, or most often tries to neutralize them with some other thought or action, which would be a compulsion. Compulsions are also defined by two characteristics. One, they are repetitive behaviors, like hand washing or ordering or checking, or mental acts, repetitive mental acts, praying, counting, repeating certain key words to themselves silently, that the person feels like they have to perform, and that driven aspect of it is an important part of the compulsion. And they're being driven to perform the compulsion in response to an underlying obsession. You observing the person, it's easy to notice the compulsion. Unless you get them to talk about it, you may not know what the underlying obsession is. The second aspect of a compulsion is the behaviors or mental acts are aimed at preventing or reducing distress or some dreaded event or situation. However, these behaviors or mental acts either are not connected in a realistic way with what they are supposed to neutralize or prevent, or they're clearly excessive. Obviously, if there is something bad that's about to happen and there's some behavior that you can engage in that will stop it, then engaging in that behavior is not disordered. We define OCD as people who are engaging in a behavior or mental act which either has no relation to the event that they're trying to prevent, or if it has some prevention to it, if it has some relationship to it, the relationship is exaggerated. For example, yes, washing your hands probably does have some benefit to preventing disease, but the kind of compulsive hand washing that people with OCD engage in is clearly in excess of what is necessary for good health. Criteria B for OCD is the obsessions or compulsions are time-consuming. They take more than 1 hour a day. I've had several patients with OCD where that's a huge underestimate. Their obsessions and compulsions easily take 4, 5, 6 hours a day. I had a patient once who every single day they were at least 2 hours late to work because they would leave their apartment, go into their car, think to themselves, oh, I don't know if I locked the door. They get out of their car, go back to the door, check the door, it's locked. Oh, good. They go back to their car. Halfway to the car, they say, wait a minute, it was locked, but maybe I unlocked it when I checked it. I better go back and check again. And they would do that repeatedly, dozens of times, every morning. Sometimes they get into their car. Sometimes they would get in their car, drive out of the driveway, get halfway down the street, have to come back and check the door again. And this was an ordeal that was repeated every single day. It was obviously very disruptive to their life in a number of different ways. But to qualify for a DSM diagnosis, it has to be at least 1 hour a day. Or if it's not time-consuming, it must cause marked distress or impairment in social, occupational, which includes academic functioning, or other social activities or relationships. Criteria C, and here we have our exclusionary category that we'll see for almost all the disorders that we look at, not attributable to physiological effects of a substance or medical condition. And D, not better explained by some other mental disorder. And it's really important to look at the other mental disorders that might account for the symptoms. That's part of what we call a differential diagnosis. In your diagnostic film reports, I will be asking you to do a differential diagnosis where you say you've made your diagnosis, but then you identify one other disorder that you did not diagnose the patient with, but which you considered. And then you would say, here's the disorder that we considered diagnosing, and here's the reason why I did not make that diagnosis. And that process is called differential diagnosis. So you want to look at the exclusionary criteria in DSM because it gives you some clues as to what are the other likely disorders that it's sometimes confused with. In DSM, there also is always a larger text section that talks about differential diagnosis at some length. Then there are several specifications. We specify whether the patient has good or fair insight into whether their obsessions and compulsions are true or not, or poor insight, where they think the symptoms are probably true, although they recognize that they might not be true. And then we have no insight, which really does get close to a delusion, which is a psychotic condition, where they're completely convinced that if they step on a crack in the sidewalk, for example, that something horrible will happen. There are some typical manifestations of obsessions and compulsions. You see on the PowerPoint slides there, I've given you the percentages. What are the most common ones? Contamination is a very common obsession. Aggressive impulses are also very common. Those are the two most common obsessions. But sexual impulses and somatic concerns. Need for symmetry is probably the one that most people think of, where people have to have their desk organized in a certain way. They count the paper clips in their top drawer and they know exactly where they are. Most people who have obsessions have more than one obsession. You see 60% do. Compulsions also fit into certain stereotypical categories: checking, washing and cleaning, ordering, and arranging. Those are the most common types of compulsions that we see. My grandmother, who I loved dearly and who lived literally right outside my bedroom, we were basically roommates for while I was in high school. She had a number of neurotic problems, one of which were compulsions and obsessions, and she was definitely a cleaner. And whenever she got nervous, which was almost always, she'd start cleaning, and my mother loved having her live with us because you could just put her in whatever room needed cleaning, and she'd start cleaning it. And so if you wanted to clean the living room, you just call Grandma into the living room and start talking to her, and you didn't have to ask her to clean the living room; she'd just start cleaning it. And then if you wanted the kitchen to be cleaned, you could just say, "Grandma, can you come in the kitchen? I got to talk to you about something." And you'd say, "Oh, I'm thinking of going camping tomorrow," and she'd get really nervous, and then she'd start cleaning the kitchen. So as you see there, women are more likely to be cleaners and men are more likely to be checkers, which is interesting. And it seems to be an exaggeration of certain stereotype gender roles. Checking is based on the idea of protecting the home, and cleaning, of course, is the idea of taking care of the home. So it's not clear if there's some evolutionary or biological basis for that gender difference, or if that represents the way that we socialize men and women in most societies. OCD and depression, as we've talked about, there's high comorbidity between anxiety and depression, and that also extends to OCD and depression. 66%, about 2/3 of people diagnosed with OCD at some point in their life will also get a diagnosis of major depressive disorder. Depression, in fact, may be an important part of what maintains OCD symptoms. The depression may be part of what keeps the OCD symptoms going. And of course, OCD symptoms are very depressing, and so it goes back and forth. Prevalence of OCD is 1.6% lifetime. In any 1 year, about 1% of people have OCD, which is about the same percentage as the population that has schizophrenia. Most people have both compulsions and obsessions. About 25% have only obsessions. About 5% only have compulsions, which probably Those are people who at one time did have obsessions, but they don't have the obsessions anymore, but the compulsions have become habitual. OCD is more common in women than men. Not hugely, but about 55 to 60% of people with OCD are women. It's more common in boys than girls, though. So in children, OCD is more common in boys. In adults, it's more common in women. Onset is earlier in males than it is in women. The peak age of onset for OCD in males is 13 to 15. For women, it's 20 to 24. We'll see in general as we go through our list of psychiatric disorders that early onset for any particular disorder is typically associated with more severity and more resistance to treatment. It often is also associated with more biological, neurological, genetic basis. OCD and OCP. OCP is obsessive compulsive personality disorder. That's in some ways an unfortunate name because it gets it easy to confuse with obsessive compulsive disorder. They are quite different from each other. Probably a better term for obsessive compulsive personality is perfectionistic personality disorder, or maybe over-controlling personality disorder. Those are the two main characteristics of that personality disorder. One reason why the name is unfortunate is that people with obsessive compulsive personality disorder don't have obsessions and they don't have compulsions. So it's not clear why we're using the terms obsessive and compulsive. And people with OCD are not more likely to develop or to have obsessive compulsive personality disorder. If you have OCD, the rigidity and order in your life is there for a specific reason, which is to prevent anxiety. In obsessive compulsive personality disorder, the rigidity and order has become an end in itself, not simply there to for the practical reason of warding off anxiety. Although there is some evidence that people with obsessive compulsive personality had very demanding and punitive parents, and the perfectionism is probably in many ways a response to that. We'll talk more about the personality disorder when we talk about personality disorders in general later in the quarter. There are three main theories as to what causes OCD: psychoanalytic, cognitive behavioral, and neurological. Look at those briefly. Psychoanalytic theory is that obsessive thoughts defend the patient against anxiety caused by other more threatening thoughts and impulses. It relies on the defense mechanisms of displacement and substitution. Marty Seligman gives an example of a patient he had once who had a color obsession. She literally could not look at any of the colors that are associated with fire, red, orange, or pink. If she does look at those colors, then she starts to tremble and get hot all over, feel dizzy and sick. What would we call that? She begins to have a panic attack. She knows it's ridiculous and not based in reality, but that doesn't make her feel any better. The only thing that does make her feel better is to look at a neutral color like blue, green, or brown. That's her compulsion. That's the ritual she engages in to ward off the anxiety. Psychoanalysts believe that there's an underlying anxiety-provoking thought here, an obsession, a disturbing obsession. Freudians would say it's the actual unconscious wish, in this case, that her mother would die of a fever. She was sick. Her job was to take care of her mother. And the psychoanalyst would say that she has an unconscious desire for her mother to die of the fever. And even though the patient knows at some level that it's illogical or irrational that her thoughts could harm her mother, still engaging in the thought I wish my mother would die is a source of tremendous anxiety, which she then feels compelled to engage in a compulsion to ward off. Cognitive behavioral theories, I think, are particularly helpful for obsessive compulsive disorder, particularly the idea of thought action fusion. Thought action fusion, which is a hyper vulnerability to anxiety that result from thoughts. People with thought action fusion tend to equate having a thought with acting on the thought. This may be caused by hyper responsibility and guilt. They may have had a childhood in which they were often punished for having inappropriate thoughts, or told that if they engaged in dangerous or bad thoughts, something bad would happen. They may have had a bad experience. Young children often have engage in thought action fusion all the time. And if something bad happens, they often blame themselves, even though it's impossible that it could be their fault. A stereotypical example of that would be parents of a 5-year-old child get a divorce, and the child believes it must be their fault because maybe the father punished them, and they kind of said to themselves, "I wish he would go away." And then 2 weeks later, the parents say, "Mommy and Dad are getting a divorce." The kid thinks it's my fault because I was wishing that Dad would go away. Now he's going away. It's because of me. That would be thought action fusion. And when something like that happens, it tends to profoundly reinforce that idea that negative thoughts or bad thoughts can get translated into action in kind of a magic way. Also, the presence of anxiety or depression seems to impair the ability to distract yourself from difficult or bothersome thoughts. Most people, when they have bad feelings, they can change the subject in their head. But the more anxious and depressed you get, the harder it is to change the channel or to change the topic in your head, which makes you more anxious, which makes it more difficult to distract yourself, which makes you more anxious, and you get caught up in a vicious cycle. The compulsive ritual provides a temporary distraction and relief from this cycle by removing the anxiety. The compulsion becomes negatively reinforcing. You feel better because you're no longer experiencing this anxiety that you're stuck in, which of course increases the probability that you would engage in the compulsion again in the future to get the same relief. The thought action fusion issue often raises questions about its relationship to religion. Are religious people more likely to suffer from obsessive compulsive disorder? It turns out there is evidence that the strength of religious belief is correlated with the severity of OCD symptoms. Not the content of the belief, but the strength of the belief. The more, I don't want to say obsessed, but the more strongly you adhere to your religious beliefs, if you have OCD symptoms, they tend to be stronger. But no one particular religion is more likely to be OCD than others. Why would that be? Some people suspect it might have something to do with a tendency for religious people to be taught that some thoughts are just as bad as actions, and the thoughts must be avoided. Within the Christian religion, the classic example of that is Matthew chapter 5, verse 28. But this is Jesus talking, "But I say unto you, that whosoever looketh on a woman to lust after her hath committed adultery with her already in his heart." That's really a classic example of thought action fusion. And there are people who literally believe that what Matthew 5:28 means is that it's just as bad to look at a woman and have sexual thoughts about her as it is to actually have sexual intercourse with her. I wish I was with you in person so we could have a conversation about that, what I'm about to say. I don't want to offend anybody, but I think equating those two things is obviously absurd when you consider it a little bit more deeply. Um, Looking at a woman, if a man looks at a woman walking down the street and starts thinking about what she might look like naked, or starts engaging in daydreams about what it might be like to have sex with her, we certainly could think about a number of negative consequences to that, objectifying women and not treating them with respect, um, taking away your thoughts and interest from a partner that you may already have, a wife or a girlfriend. But it's obvious, I think, that thinking those sexual thoughts about the woman are not the same as if the man grabbed that woman and threw her down on the ground and had sex with her right that minute. That would be much, 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 much worse than thinking about having sex with her. Certainly, I know my wife, while she may not be happy if I was having sexual thoughts about another woman, she certainly would be much more unhappy if I was actually having sex with another woman. So the thought and the action are completely different things. And yet there are religious people, there are Christian people who believe that thinking about having sex with somebody is just as bad as actually having sex with them. And that is the habit of thought that does lead to obsessive compulsive disorder. I think Matthew 5:28 means something much different than that, which, if you're interested, come see me sometime when I get back and we can have a conversation about it. All right, let's look at some of the neurological evidence for OCD. There are 3 lines of evidence for a neurological role. One are what are called neurological signs. These are soft signs. There's no clear, specific relationship between these signs and OCD, but we know that people with impaired fine motor control, involuntary jerks or tics, impaired visual motor skills are more likely than the average population to have obsessive compulsive disorder. OCD is comorbid with diseases like epilepsy, Tourette syndrome, history of a viral brain infection. So that's a reason to suspect that at least one contribution to OCD is a brain which has in some way been impaired or thrown off. A second line of evidence comes from brain scan abnormalities, which show higher electrical activity in the cortical striatal thalamic circuit. And we talk about a number of these different circuits. I've already given you some for anxiety disorders. The orbital region of the frontal lobe, the caudate nucleus in the basal ganglia, and the thalamus. That circuit in the brain tends to be more active in people with OCD. And we, from other evidence, know that these brain areas are involved in filtering out irrelevant information and also for managing repetitive behaviors. So, if one way of thinking about OCD is it's somebody who's unable to ignore or filter out irrelevant information. They pay just as much attention to irrelevant details as they do to relevant details. And so rather than focusing on the people around them or their problems or their tasks, they spend a lot of time thinking about germs or microbes or whatever it might be. A third line of evidence for neurological substrate to OCD is the content. The content of obsessions is not random, but has significance, it seems, many argue, in the context of evolution. Grooming and physical security, which underlies cleaning and checking compulsions, is rooted in a basic primate concern for grooming and physical security. If you've ever gone to the zoo and gone to the monkey cage, you see the monkeys spending a lot of time grooming each other and themselves. And we know in the Phobias, they are not random either, the specific phobias. They take the form most often of stimuli which have some basis or grounding in that make evolutionary sense, which suggests that there may be some disruption in primitive parts of the brain in people who have obsessive compulsive disorder. What about treatment issues? Until relatively recently, into the 1990s, obsessive compulsive disorder was very refractive to treatment. Refractive means hard to treat, resistant to treat. No matter what we did, people didn't get better with OCD. Things have gotten better in the last 20 years, 25 years or so. Now there are 3 kinds of therapy which show some effectiveness. They're not magic. They don't make it go away for everybody, but much more effective than what we had up until relatively recently. One is drug therapy, and again, as with panic, drugs that increase serotonin, which are usually used to fight depression, have also been found to be effective in dealing with obsessive compulsive disorder. Tricyclic antidepressants and also the SSRIs like Prozac and Zoloft and Paxil have shown some effectiveness. About 60%, maybe 2/3 of people who get these drugs show some response, some significant response, some significant improvement in their symptoms. But as I've said before, these drugs do have side effects, drowsiness, constipation, and loss of sexual interest. And again, remember that the drugs that we give people who have OCD often lead to loss of sexual interest. And one problem with that, of course, is that we have a medication compliance problem. When the side effects of a drug are uncomfortable, then people are less likely to take those drugs. And the benefit, while significant statistically, is still relatively moderate. And relapse is almost 100% as soon as the drug is discontinued. Again, I think a more promising treatment is, in this case, a behavioral form of psychotherapy called exposure and ritual prevention. It's also known as ERP, exposure and ritual prevention. Sometimes the R stands for response prevention. It means the same thing, the ritual or the response being prevented. Make sure you are very clear about ERP, that you know what ERP is and that you can recognize it when you see it and use it to analyze certain situations that you might be exposed to. In ERP, we first engage the patient in systematic exposure to the thought or the situation that we're afraid of. And again, in dealing with any anxiety or anxiety-related condition, we often will be looking at some kind of exposure-based treatment. We're thinking of the symptom as a conditioned response, and we know the best way to eliminate a conditioned response is through extinction, which basically is exposure. While we are exposing them to the feared thought or situation, we also try to prevent the ritual, either the thought or the action, the compulsions that the patient engages in. We prevent this in a variety of ways. We might just encourage them verbally, having prepared them beforehand, and then also during their exposure to not engage in their ritual. We may have some kind of electronic or video monitoring of them so we can check to see if they in fact are inhibiting their ritual. In extreme conditions, we may hospitalize them or in other ways restrain them, of course with their permission, to prevent them from engaging in their ritual. And then, along with the exposure and the prevention of the response, we help them engage in reality testing, where we get them to look at their situation, identify what are the actual threats or dangers, How realistic is it to be worried or afraid of anything bad happening? Check after a half an hour, after an hour, after 5 hours, after a day. Has anything bad actually happened? And in this way, they're more likely to realize the benefits of the extinction or the exposure. Often what we also do, of course, is teach the person to relax. And so while they're being exposed to their feared situation and prevented from engaging in their ritual, we encourage them to engage in their relaxation techniques, which decreases their anxiety and thus their need to engage in the compulsion. Again, I want you to think about that. Apply that to any situation you might be exposed to in the next couple of days and see if you see any examples of that. If it works, what it's doing is extinguishing the anxiety response, which then eliminates the need for the compulsive behavior. A third treatment that's been used in recent years for OCD is rather extreme. It's called psychosurgery. In this case, it's a lesion of the cingulate bundle, so it's sometimes called a cingulotomy. The cingulate bundle is part of the cortical striate thalamic circuit that we talked about earlier as part of one of the brain circuits that seems to be overactive in OCD. It's the most common surgical procedure in the treatment of both OCD and depression. And you might think, well, how is OCD and depression related? But when you think about it, you'll notice that a lot of depression is also stubborn thoughts that you can't get out of your head, which is similar to an obsession. This kind of psychosurgery is a very extreme procedure. It's only used in refractory cases. Again, remember that word means cases are not responding to either drugs or behavior therapy. In fact, you can't get psychosurgery until you demonstrate trial with 2 medications, either SRIs, which are the tricyclics, and SSRIs. You have to have tried at least 2 different drugs, each of them for 10 weeks. And then you have to have tried behavior therapy for at least 5 years. And I've had both the medication and the behavior therapy not work. That's refractory. And then, and only then, might they start to consider the psychosurgery. Efficacy of the treatments, ERP has an 85% response rate, which really is quite dramatic. Drugs have a 50 to 60% response rate. Again, the combination therapy is no better than ERP alone. The relapse rate is much lower with ERP, so you get the idea that I think ERP is a better treatment than medication, although again, medication under some circumstances may be a good way to start so we get a faster response and then transition over to the behavior therapy. As we say, psychosurgery is only an option in extreme refractory cases, although even then, I've never had a patient that has needed psychosurgery for OCD, and I think I'd be really reluctant about recommending that, but it is an intervention that seems to be effective with relatively few side effects. All right, very good. That brings us to the end of our lecture on OCD. I see by the clock on my video that we've been going for 48, almost 49 minutes now, so it's just about right. I'm going to turn off this video, and then in a minute I'm going to make another one for post-traumatic stress disorder.